Welcome everyone to Office Hours, where we explore the most pressing topics in revenue cycle management. I'm Stuart Newsome, your host, and today we're diving into an essential topic for pathology practices, mastering billing, coding, and collections to optimize revenue. But before we begin, we have some exciting news to share. MedReceivables Advisors has officially joined the Affinix family. This is something we're very, very excited about. This partnership brings together deep expertise in pathology revenue cycle management with solutions that provide even greater support to pathology groups nationwide. Now, to talk about this and share his incredible insights on this, as well as what's going on in the world of pathology billing, I'm thrilled to welcome our guest, David Smith, who's the Chief Operating Officer of MedReceivables Advisors. So, David, really excited to have you join us today and to be a part of our family. And just want to check, how are you today?
Well, first of all, Stuart, I just want to say thank you for the intro, and I'm doing great. We're very excited to be part of the Infinex family, and everything that brings with it, including all of the IT support and additional security for our clients, which will be an integral part of our process. And we're very excited about moving forward with everybody.
Oh, and that's fantastic. I know, and everyone here is just, ready to dive right in. It's been, a long time coming. And so it's almost like, yeah, it's a celebration, but yeah, we can roll up our sleeves and get to work, right?
Right, exactly. Well, we never stop getting to work.
That's
We're always
right.
at work.
That's
That's
right.
the
Exactly.
that's the thing about this business. It's a 24/7, 365 business. That's what it is.
That's right. Exactly. Exactly. So speaking of business, this discussion today is going to be a collaboration, that we're going to really kick off a two-part series. So this is part
Sure.
one. And it's all about pathology revenue cycle management. And so we're going to break down how changes in managed care rates are impacting billing, why outdated billing practices could be costing you a lot of money, and then how to prevent the most common denials. That's the key right there. It's probably the most popular. What you can do to make sure clinical pathology payments aren't undervalued by insurers. Keyword there is undervalued. So, as always, we have a Q&A session at the end. So if you can feel free to drop questions in the chat as well as comments. We also welcome comments, not just questions. And we'll get to those as we're able. So
Sounds
David,
good.
I'm just going to dive right in. David,
Sure.
can you just share a little bit about your background and how the pathology space and also kind of what led you in specializing in billing, coding, and collections, particularly for pathology?
All great questions. So I've been officially in the pathology billing business for the last 35 years, but I've been around pathology in the laboratory my entire life. My dad was a pediatric pathologist here in South Florida for over 40 years. So I grew up in the lab, and I grew up listening to all the trials and tribulations and billing problems and collections that go back to the 70s, 80s, and 90s. And then obviously, as the world has changed in the last 25 to 35 years, we've been able to expand what we're able to do and how we're able to do it, and really able how to specialize in everything associated with pathology.
Nice, nice. And so I'd imagine there's a lot of change that's happened through that time and because when you started, I mean, I know I started like 29 years ago as well, but it's like the technology changes and still, but yet some things still remain the same
Well,
with.
it's exact, Stuart. I was just going to say, the amazing part about it is that we're still fighting the exact same issues in pathology today that we were fighting 35 years ago.
Mhm.
Pathology, I would say through the 70s, 80s, and 90s had its issues as it relates to like payer mix and how the process of both clinical and anatomic pathology was processed and paid. And then in the late 90s, a lot of the managed care companies started fighting back and not wanting to pay for the professional component of clinical pathology, which is when we really started having to change the course and direction of fighting for those services through a lot of litigation, and a lot of filing lawsuits against every managed care company to try to delineate our practices and our clients, and really kind of work towards an amicable solution that was good for the pathologist.
Right, right, right. And so you're alluding now to kind of that evolution over time of how managed care rates, have changed. And But what are some of those steps that practices should take to prevent revenue loss due to some of those outdated billing practices?
Well, I think initially, I think a lot of times what happens is most billing companies and most groups look at the billing process as more of like a commodity. They want to look at it as though it's like a credit card business where we just, put charges in and put charges out and collect some payments and write off the balances and maybe an appeal a claim here and there. That's not the way the process works. I mean, the process is really it's mostly the same for everyone, but there are slight differences that are associated with every practice, every state, and every hospital. So, initially it's really reviewing what you have, and it's making sure that number one, you're capturing everything in all departments in the hospital that the pathologist has the oversight and supervision for. We find almost 95% of the time when we pick up a client that there's data that's missing from the billing files that they're not aware of. And it could be different. It could be as much as an entire department, or it could be emergency room claims, or it could be point of care testing or chemistry. There's so many different scenarios that we've seen along the way. So the first step is really to kind of just check to see, am I getting A to Z? And what is A to Z for that particular group? Then the second step is reviewing and looking at all of their managed care contracts. Are they participating? Meaning, do they have an actual contract and managed care agreement that has been signed, that has a fee schedule? Does that fee schedule include the professional component of clinical pathology and anatomic pathology based on different payment rates? What we continuously see is billing companies are pushing providers to take the easy road to just sign an agreement that excludes basically the reimbursement for the professional component of clinical pathology. And what we see that with the bulk of our clients, anywhere between 40 and 60% of the total collections come directly from the professional component of clinical pathology. So it's diving in, looking in to see what you've got with your managed care, what the billing files look like from the insurance company, not from the insurance company, from the hospitals, excuse me. And then really putting the processes in that are associated with making sure that you're capturing the data, reviewing and making sure that you're getting paid, you're supposed to be getting paid, making the decision whether you should have a managed care contract or not, and then getting in obviously to all of the back end as it relates to insurance follow-up and denial review and appeals. So there's a lot of different steps associated with the process.
Wow. So it sounds like the main thing is just building an awareness, because everyone's kind of been used to doing the same thing for so long. It's kind of
That's
like
exactly right.
our process. So just building awareness, and they're like, have you seen any aha moments where
I
they're
would
like,
say 100% of the time, what's interesting about us is I would say that most of our clients really come from references, or they come from a time when there's a fire, and they think that there's a big problem and that they're dealing with. And in every one of those cases, whether there's a fire or there's not a fire, within 5 minutes of a conversation, there's multiple aha moments. And a lot of that can include, when was the last time somebody did a coding and documentation review for you? When was the last time you did it at an audit to make sure that you're capturing what you should be? When was the last time somebody looked at the payments to make sure that you're getting paid what you're supposed to be? When was the last time, somebody looked at your managed care agreements to make sure that you should even have them in place?
Mhm.
So when was the last time you had litigation? When was the last time you sued an insurance company for not being paid for the proper things? When was the last time you looked at the appeal process? What we see over and over is billing companies can do an okay job of getting claims out the door. They usually are not looking at the changes that are always occurring on the hospital side as it relates to new laboratory testing or new hospital systems that are implemented. And so, again, we don't, you can't fit everyone into the same barrel, but for the most part, the list of questions and things like that we ask always generate aha moments. And it's every client. It's literally every client.
Do you get any pushback, from them? Like they go, oh, you can't do
No, I would say no. The only time, it's interesting that you say that, because we were on with a new client today and we were talking about coding and compliance. And we appreciate the pushback, because what happens is that, we, especially in the beginning, we're reviewing a lot of pathology reports and making sure that not only is the coding being done properly, but the documentation is being done properly. Because usually what happens is that you're not fighting over an audit. Usually what you're usually fighting over is having to appeal claims. And when you're having to appeal claims, you have to make sure that the documentation supports what the CPT codes are that you're billing. So from time to time, the pushback that we get from clients is, well, we don't agree with the rules and rules related to the compliance, associated with, the various coding rules. And so what I said to this particular client today is, I said, well, we'll have this conversation today, and then we'll have it again in 3 months when we do the next review. And so it gets to this point where we have a comfort level with each other, where the pushback is not, it's an important piece of the puzzle. We don't look at this as though it's we're the end all be all to everything. Every client always has insight into different issues and things like that we might not have ever thought of. And so getting their feedback and really having a participation in a flow of information back and forth, not just, oh, we take care of everything. It's, yes, we take care of everything, but we're going to report back the things we see. But we also want to educate you in such a way that these are the things that you should be looking for as well. Because the pathologists are the first line of defense. They're the first ones to say, wait a minute, I looked at the monthly report. I know we're doing peripheral blood smears. How come you're not capturing them? Or I know that we do 50 a day or 20 a day or 10 a day. How come I only see 3 on the reports? And usually it's because there's always some outliers and flows and things like that in the process. And it's usually the same for every pathology practice. So it's really just working through and creating a process and a flow that works for that particular group and that particular hospital system.
Right. And kind of a side question here, because you'd mentioned the professional component, and I know we've talked about insurances, but I remember a conversation we had several months back about, the hospitals and how they play into that a little bit. And maybe the professional component is just absorbed by the hospital. Is that something that's still prevalent today?
Well, what happens in that situation is that the hospital is not billing in any kind of way for the professional component of clinical pathology at all. The only time clinical pathology is paid in a different manner in most states is for Medicare and Medicaid patients, where the payments do directly go to the hospitals, and the hospitals are supposed to be paying back a pass-through for those services. All the managed care plans, though, are built in a different manner. Now, the managed care companies will say, oh, we like to follow Medicare rules, okay, which implies that they're paying for the professional component of clinical pathology to the hospital, but they're not. I've never seen in 35 years an agreement where a hospital was billing for the professional component of clinical pathology for any managed care company, both commercial, HMO, exchange plan, none of it. It doesn't exist. It's not even part of the process. So what we do in that case, when we have to fight with the insurance company, is we go back and we litigate it, So we have to make sure that when they're denying it and saying that it's a non-covered service, or they're saying it's an invalid modifier, or they're making up some sort of contractual adjustment that really is not applicable, we appeal those claims. It's a huge difference between us and everybody else that's out there. You can't litigate unless you're appealing the $5 and $10 balances. So if you don't follow the rules that are specific to that particular payer, you're leaving yourself at risk to where you really don't have any ability to go back and fight with the insurance companies to collect the money. So we put all of the effort on the back end into those denials to make sure that we're appealing it properly with language that has been provided by our healthcare attorneys that help to give us a path forward to hopefully mediate and settle and get a contract going forward. But if we have to litigate it, then we litigate it. So it depends on each carrier, and it depends on the relationship with the hospitals. But again, in doing this for so many years, we've never had a hospital say, no, you can't go after the insurance company to get paid what you should be getting paid for.
Right. So, and speaking of denials, what are the most common denials in pathology? And
Well,
what strategies do practices need to implement for improving that accuracy?
it's a great question. I mean, again, I really separate them out into two classifications. There's the denials that we receive for anatomic pathology, and mostly what we receive in that kind of situation is when multiple units of the same CPT code are billed. Immediately it flags every edit with every insurance company, including Medicare and Medicaid, and even adding all of the proper modifiers to identify the correctness as to why you're billing those particular cases. Still requires you to have an appeal with a report, with a pathology report. This goes back to the importance of making sure that the reports have everything that you need in order to be able to fight and appeal the claim. Okay. So a lot of them are mutually exclusive edits where they say you can't do this service and that service in the same day on a patient, or it's multiple biopsies on different jars of a sample that are coming in, and it's us having to fight that. It's also having to fight the various stains that are usually performed, immunoperoxidase stains or special stains that, especially on some of the larger cases, you can have 6, 12, or 20 different types of immunoperoxidase stains that are run on a case, and there's only one CPT code that provides information for the front part, and a second CPT code, which is like an add-on. So 88341 and 88342 are the two main codes associated with immunoperoxidase stains, but they encapture all of the different types of stains. So there's many different types of stains that are used, especially to rule out different types of cancer and things like that. And so, again, that's where the documentation is so important, because then you can go back and see the list of every stain that was performed. It's not just an 88341 times 6. It's an 88341 times 6. And then on the report, you're able to see here's 1, 2, 3, 4, 5, and 6. So that's on the anatomic side. On the clinical side, it's a whole different ball of wax. On the clinical pathology side, it totally depends on the carrier. They're denying for professional component of clinical pathology services, saying it's included in the payment to the hospital. It's billed with the wrong modifier. You're not allowed to bill, pathologists are not allowed to bill for a professional component with a modifier 26, although that's the only way you can bill for professional services in a hospital.
Exactly.
Period. There is no other option. And you can't have a technical component of a lab without a professional component of a lab.
Exactly.
And the pathologist in every hospital is responsible for the oversight and supervision of everything that goes on in that hospital for all the laboratory departments. And so, again, it's making sure that we understand the denial flow from each of those insurance companies, and we set up the appeal process to make sure that we're appealing it differently to each carrier. So what Cigna wants is different than what Aetna wants. What Aetna wants is different what the exchange plans wants. What United Healthcare wants to see is different. And then once we've got enough information and we can see whether our denials are working or not, we can change the denial process and denial flow and language. We can inform the client of what we believe are the next steps, bring in an attorney at no cost to the client. It's generally speaking all done on a contingency basis with the attorney. So there's no downside, for the client. And we put forth all of the upfront costs by making sure that we're appealing everything. And to me, it doesn't matter if a case takes a year, 2 years, 3 years, or 4 years. It's just part of the process for the client. You take the low-hanging fruit with all of the other items that take a really long time to grow, and to the point to where you get a piece of fruit. So,
Right.
you can't take the easy stuff and disregard the hard stuff. And I think what we see time and time again is most billing companies just walk away from the hard stuff.
Yeah, exactly. Just the low hanging fruit. And I would imagine that there's medical necessity issues, especially on the clinical side, but also the anatomical side when they go to, like, was it the left? Was it the right? Where was it bilateral?
Yeah, I mean, it's interesting on the clinical path side, remember the pathologists aren't ordering the tests.
Mhm.
As it relates to the medical necessity, these patients are coming in and they need to be tested to make sure that everything is in order. Okay.
Mhm.
So
Mhm.
obviously it's a different run of tests for emergency rooms and outpatients than it is for inpatients. But referred physicians are not ordering tests unless they're medically necessary. They're not just ordering extra tests for the heck of it. They're
Right,
ordering the test because they need it in order to dictate what the next step is in the patient's care,
right,
period. So
right.
you could have a $20 clinical path laboratory test, which is going to decide, the next 6 days of treatment for that patient. Okay.
Mhm. Mhm.
Especially when they come into the emergency room. And what's one of the good things that's come out of COVID has been there's been a significant advancement in the type of testing and the level of testing that's available to really pinpoint, what kind of treatment patients need early on. And so it used to just be like a patient would come in to the ER, with symptoms, and they would test them for flu A, flu B. Now it's flu A, flu B, it's COVID, and then it's a huge respiratory panel of 12 to 25
Yeah,
targets of different things. And then they can pinpoint it and say, okay, it's not COVID, so we don't need to give them Paxlovid or whatever the drug is of the day. It's this. It's not flu A, it's not flu B. They've got something else. And then it helps to dictate how that patient's going to be treated.
yeah,
So the medical necessity argument is not an argument.
good. Yep.
We don't really, it's not something that we ever face, again, because the pathologists aren't dictating what's performed.
Right, right. And it just seems that medical necessity seems to be a game that payers are playing these days.
That's all it is.
Yeah, it's always been, even to nitpicky things like with the diagnosis code, didn't determine if it was right or left.
Correct.
Like, okay, so um, you just got to pay attention to those, make sure the coding is accurate, just like you are
Absolutely.
proper modifiers and things of that nature. So,
Proper modifiers and proper diagnosis
right,
codes. So I
right,
mean, a
exactly.
lot of times what we see with different groups is they're getting a lot of incomplete information from the billing files. So
Mhm.
again, one of the first things we do is we look to see how the billing file is created. And then we put it through our proprietary process to make sure it has all of the necessary fields, including the abstracted information, so that we've got the best data to present to the insurance company so that the first time through we get paid.
Perfect.
Okay. And the reality is, even with a super clean claim system, we still see that 35% of the total collections comes from insurance follow-up and appeals.
Mhm.
So it's
Yeah,
an integral part of the process that if you don't spend the time and the dollars on, you will not have the success.
yeah. You gotta do the time, and like you said, do the hard stuff if you wanna have the fruit. That's for
That's
sure.
very much exactly.
So with clinical pathology, I know it seems, payments are often undervalued, by insurance companies. So, and you alluded to this a little bit already throughout your answers, but, why is this the case? And what can practices do to improve collections in this area?
Well, again, I mean, I think it just walks back through the whole process again. I think, listen, initially in all of our litigation, it had come out that the original reason why some of the managed care companies had made the decision to cut the professional component of clinical pathology was just so they could save money.
Yeah.
It wasn't. There was no other reason as to other than really to save money.
Yeah.
And I
Cost
go back.
control.
That's right. And I go back to some of our early cases back in from 1999 to 2004, where we really went through litigation in the process. And it was very clear that that's what was happening.
Mhm.
So it's being meticulous to really understand what your contracts are, where and when it makes sense to have a contract with a payer. And if you've got a contract with a payer, it's making sure that you're being reimbursed as you should be, for the tests accordingly. And again, what we find most of the times is some groups are willing to take a higher rate for anatomic pathology and nothing for clinical pathology. And that's usually under the direction from their billing company because it's an easier way to process the claim. I don't look at it that way. I look at it as though I want to collect every possible dollar I can for the client. And knowing that 40 to 60% of the collections are going to come from clinical pathology, depending on what type of hospital it is enough for me to want to fight the battle.
Right. Right. Well, excellent. Well, that's all the questions I have. I'm going to turn it over now to the audience and see if there's any questions that anyone out there has. So just as a reminder, please put questions in the chat. If you have any, we'll be able to get to as many as we possibly can. Um, so I do have one here, is, what are some of the biggest compliance risk pathology groups face when it comes to billing and coding?
Well, again, the rules are very clear as it relates to anatomic pathology coding. I would say most of the time, audits and compliance come up on anatomic pathology, but not 100% of the time. So the best thing to do is to really make sure that you've got someone that is giving you or the group coding feedback and continuous education. And the education process never stops. I mean, we're meeting with our groups at a minimum of quarterly to make sure that we've discussed and educated them on all of the quality initiatives, any of the coding changes, and making sure that if they've got new doctors in their process or there's a new hospital system in place, that they're following all the rules, and not just letting someone who accessions the case allow that to be the charge that's associated with what the billing company might bill on the anatomic side. On the clinical pathology side, it's making sure that the reporting process for the actual clinical path reports is in line and in place, and making sure that the headers on the report show exactly where the tests were performed in an easy manner, so that if you are ever audited by Medicare and Medicaid, it's easy to identify and find who requested the test and be able to find the results very, very quickly. I would
Awesome.
say those are like the main points.
Sure, sure. And here's another question. Are there specific payer trends or policy changes affecting pathology reimbursement that practices should be aware of? I mean, obviously, I'm always telling people, yeah, check for any regulation changes because there always are changes that
It's
pop.
the answer is it's every day, all day.
Yeah.
So what we do see for the most part is payers make changes usually quarterly. I would say that's on average, but that doesn't mean that they won't start something. Let's just say that's specific to molecular pathology. They could decide tomorrow that we've changed our rules. We no longer pay for molecular pathology in a hospital-based setting, or
Right.
we only will pay for it in a reference lab setting. And it needs to, you need to check these 10 boxes of medical necessity before you submit the bill to us. And if you don't include that on the claim and you don't have the backup data, you're not going to get paid. So it's the answer is yes. It's all day, every day. It's being dialed into what those denials look like and really analyzing them on a monthly basis. So, what you think is okay today is not okay tomorrow. And what one client has and may be working in one state is not the same in another state for the same,
Right.
for a different client with the same payer.
Right.
I looked at that yesterday, interestingly enough, for an exchange plan program we were looking at. And in one state, they're using one denial for the same clinical path denials, and in a different state, they're using something different. And then for participating clients, they're using one denial code in one way, and for non-par, they're using another one in a different way. So it's it's just being able to jump through all the hoops to look for the various things. And again, it's not getting complacent in a process that is literally, it's like we're in quicksand. Okay. You're constantly, if you just stay still, you are going to sink to the bottom.
Right. That's exactly right. Awesome. Awesome. Well, I think that's it. I don't see any other questions coming in. David, this has been an incredible discussion. Really, thank you again for sharing your expertise and joining us, and looking forward to having you with us next month.
It's my pleasure. My pleasure.
Yes.
Thanks so much, Stuart.
Yeah, so we're going to have everyone, the second part of this series is going to be next month, so stay tuned to look out for that registration as we dive deeper into the litigation strategies in pathology RCM. So if you found today's session helpful, be sure to check out our upcoming office hours episodes. And thanks again, everyone, for tuning in, and we'll see you next time.
Thank you.